Hi, everybody. My name's Leah Delaney. I'm one of the third-year general surgery residents here, and I'm very pleased to be presenting our work today, Utilization of Thyroid Ultrasound and Surgery after GLP-1 Receptor Agonist Prescription in the US. Oh, I think that this, oh, here we go. We have no disclosures that are relevant. So as we all know, GLP-1 receptor agonists, such as semaglutide, have become increasingly prevalent and have become the mainstay of treatment for both obesity and diabetes in the United States since FDA approval in 2017. It's estimated that about 12% of the US population is prescribed one of these medications. There's only one black box warning for these medications, and that is that they're contraindicated for patients with a personal or family history of either MEN or medullary thyroid cancer. This is based on preclinical rodent studies, and there's been no causal association shown in humans. However, with any medication prescribed on this scale, there's a risk of unintended consequences, either from medication side effects or from changes in routine practice that occur. And there's been this growing concern that a heightened awareness, both from patients and providers, of this potential association with medullary thyroid cancer is leading to overdiagnosis and overtreatment of thyroid nodules among patients who are not otherwise at risk for these pathologies. In this context, we aim to characterize the utilization of thyroid-related diagnostic and therapeutic procedures for patients who are prescribed a GLP-1 receptor agonist. We did this by conducting a retrospective cohort study using Truveta electronic health data. Truveta is a nationally representative data source that uses linked health data and has access to demographics, labs, and procedural information for patients. We first identified all patients who were prescribed a GLP-1 after FDA approval in 2017, and we performed a descriptive analysis looking at thyroid ultrasound, biopsy, and surgery within 1 year of medication initiation. And then to put this in context and see if this really represented a deviation from standard practice, we performed a matched cohort or comparison group analysis here. Our cohort of interest was new initiators of GLP-1 receptor agonists. And we used BMI, age, and sex matched analysis to compare them to patients who are initiated on an SGLT2 inhibitor, which is another class of diabetes medications, but has no association with thyroid pathology. Again, our outcomes of interest were an ultrasound, an FNA biopsy, or surgery performed within 1 year of initiation of the medication. So overall, there were about 2 million patients who were prescribed a GLP-1 receptor agonist during our study period. Of these, a little over 1 million were new initiators of a GLP-1 receptor agonist, and this was the group we were interested in order to determine if there was any temporal association between starting the medication and having any of these interventions. This group of about 1 million initiators of a GLP-1 were predominantly female and white. The mean age was 55 years, and the prescriptions themselves were predominantly prescribed by primary care providers, although 4% were prescribed by an endocrinologist. Of these 1 million initiators of a GLP-1, 1.1%, or a little over 11,000 patients, underwent ultrasound within a year of medication initiation. The patients who underwent ultrasound were more likely to be female, have diabetes, and also have their medication prescribed by an endocrinologist. And then to put this in context, again, we looked at we did a comparison of the SGLT2 control group to our cohort of interest, the GLP-1s. What we found was that patients who were prescribed a GLP-1 were significantly more likely to undergo a thyroid ultrasound within a year of medication initiation. And they were also more likely to undergo these ultrasounds sooner, closer to the initiation when we looked at long-term follow-up. When we examined FNA biopsies, we found similarly, the initiators of GLP-1s were more likely to undergo a biopsy than their control group, and they underwent these biopsies sooner. And then finally, we evaluated surgical intervention. We found that those patients who were initiated on a GLP-1 were significantly more likely to undergo thyroid surgery within 1 year of medication initiation when compared to the control group. And overall, this surgery was sooner to medication initiation. When we looked at who was getting surgery, we found that the patients were overall more likely to get a lobectomy in the GLP-1 group. And overall, the surgeries were performed for predominantly benign disease among both groups. As a secondary outcome, we looked at calcitonin, which can be used as a screening tool for medullary thyroid cancer. Interestingly, we found no statistically significant or clinically relevant difference in the rates of this lab that was ordered between our two groups. We then performed a subgroup analysis based on who was prescribing these medications. We found that patients who had their GLP-1 prescribed by an endocrinologist were more likely to undergo ultrasound within the year. And this translated to more surgeries as well. However, when we looked at our comparison group here marked in red, you can see that we had similar trends. So we think that this is less likely related to the medication itself and more likely to provider expertise or training leading to these changes. Overall, in this large nationally representative cohort of patients who were initiated on a GLP-1, we found that there was increased utilization of ultrasounds, biopsies, and surgeries after prescription. We feel this really represents a cascade effect of healthcare utilization, starting from unnecessary, potentially ultrasounds, leading to biopsies and more invasive procedures like surgery, for what in our cohort was predominantly benign disease. Although the relative differences that we're presenting here in this cohort are small, we feel that the overall absolute impact could be quite large. If over 40 million patients are prescribed a GLP-1 in the United States, this can translate to significant overtreatment, healthcare costs, and potentially patient harm. The study was not without limitations, the first of which being we can't determine within this data set the exact indication for the thyroid ultrasounds ordered, but we felt that through the comparison group and being able to do that matched analysis, that the most likely reason for the increased rate of ultrasound in our GLP-1 group was this heightened awareness around the black box warning. Additionally, our comparison group was performed among patients who had diabetes. We didn't look at patients who were prescribed these medications exclusively for obesity. It's unclear if we would have seen similar trends. However, by looking at these diabetes group, it allowed us to have a correlate comparison group with these SGLT2s and really be able to further examine if there was any difference. Overall, given what we know to be a low absolute risk of thyroid cancer among these patients, we feel this data really highlights a reinforced need for education around the indications for thyroid ultrasounds and screening, and supports the continued evidence-based approach to screening in order to prevent healthcare overutilization, healthcare costs, and potentially patient harm. Thank you all.